So this year is special. We are fortunate to have really a very special guest with us, Dr. Paul Farmer, who received an honorary degree. An honorary degree from Tulane this morning, but this is not your first degree. You graduated from Duke and Harvard. You are faculty at Harvard Medical School, and you are really a hero of public health. You have been a tireless advocate for global health and for social justice. The organization you co-founded, Partners in Health, provides health care to those in need around the world. So it's really an honor for us to have Paul Farmer as our speaker today. Paul.
Thank you. Thank you. Pray for me that I will be able to see these pages, which are few in number. I did just leave my glasses in the Super Dome. So I'd like to thank Carrie, who found them. So let me start again. Hello, dear graduates in public health and tropical medicine. You're supposed to, usually... So whether previously classed as undergrads or grad students, you're all graduates now. And are you separated, like undergraduates in the back? Yes? Hey, undergraduates. You know, when I started, even medical school or graduate student, there really weren't undergraduate programs. And you're the first wave of the legion that's going to make a big difference. So congratulations to all of you who chose so early. So just a heads up, your dean has done his job. And I'm not talking about the last 15 years. I'm talking about a month ago, he called me, insisted, in fact, that he connect. And I would say, well, I'm in Liberia. I'm in Mumbai. No, he had to chase me down. And I suspect it was to give me the message, which he did, that my talk should be short. This is New Orleans, he said. The graduates want to party. Now, does Pierre look like a party animal to you? More France than Flanders? Thank you. I need that. He has way too many degrees after his name to know much about New Orleans and its ways. And now you've all added one to your resumes, which is why I'm here. Although I must add with some pride that I got my Tulane degree today also. Yeah, finally, I was planning to attend Tulane when I was 23 years old, when I wanted to come here to med school and do public health. And that was the first year I went to Haiti. And you know, sometimes when I tell people I really hate hot weather, I grew up in Florida. I hate it. People say, well, why'd you go into tropical medicine? Well, the answer is not for the weather. But Haiti is what got me started on both tropical medicine and public health. Back then in Haiti, the ranking fads in most schools of public health and tropical medicine did not include much discussion of social justice. But as many of these schools became increasingly balkanized, Tulane managed to insist on building bridges between disciplines, between methodologies, between town and gown, and between nations, across divides. Tulane was and is the place to be for my particular mix of interests. Now, the only reason I applied to the Tulane of the Northeast I later tried also to convince my daughter to come here, and I'm very grateful to Ken Schwartz, who I assume is not here, but he nominated me for this degree some years ago. And he's the dean of the architecture student school, and I tried to go that route too. Well, maybe if I didn't end up here, could at least get a foot in the door with a child, you know, be able to stay in the French Quarter, listen to the great music. Man, I really love New Orleans. 35 years it's taken me to get this damn degree. Anyway, the reason I went to the Tulane of the Northeast was because of another interest in medical anthropology. Yeah, there's some whoopers out there in medical anthropology. Try going to an American Association of Anthropology meetings. Try going to those. They're really scary, all those. Anyway, I'd never heard of Ebola, and HIV had just been identified, but I knew even then that I wanted to be a physician anthropologist. The leading figure in that field, by my estimation, had trained at Harvard and was headed back there. I was shocked and, of course, delighted to be admitted and started medical school, get ready for this, in 1984. I know, you're thinking, I wasn't even dreaming of being born then. You're thinking, my parents weren't born then. You're not thinking that, are you? That's right around the corner. Anyway, 1984. Medicine is becoming, in Lewis Thomas's term, the youngest science. But Haiti was on my mind. So was my father, who died suddenly just before I started medical school. He was playing basketball with one of my brothers, and his death at 49 led us to wonder what difference ready access to primary care might have made. It wasn't the first time, of course, I asked myself that question. A year in rural Haiti left no doubt that serving as a physician in a medical desert would save lives as long as one had access to the tools of the trade. Whether one considers preventives, like vaccines, or diagnostics or therapeutics, these tools were coming from basic science. And that's another reason balkanization and too many silos is bad for public health. It's not prevention versus care. It's not basic science versus social science. Public health needs to turn away from those false dichotomies and keep focused on the equity agenda. I knew back then that I'd had a personal glimpse of what it meant to live in places where the fruits of discovery science were absent or unevenly shared. That meant in 1984, as now, not only Haiti, but also parts of this country. As we were later reminded by Katrina, some of these clinical deserts aren't too far from research universities like Tulane. New Orleans, New York, Boston, Miami, San Francisco, pretty much all the bigger US cities were just then facing new problems, like AIDS. That's why TB's recrudescence in these cities was often shrugged off. It's just HIV, it's just AIDS. But a new set of federal policies, which were alas old and long-standing in some states, had been cobbled together in a war on drugs. A rapid spike in prison populations ensued, and those behind bars were soon mostly men of color. Since people are sent to prison as punishment, not for punishment, public health champions fought back against tuberculosis in American prisons. They knew they couldn't do that without integrating prevention and care. After all, the way to make someone with TB non-infectious was and is to diagnose promptly and treat effectively. Now, many commentaries, and this is where anthropology came in, many commentaries on high rates of disease and poor outcomes within US jails and prisons continued to focus on the alleged cultural, cognitive, and personal deficiencies of those sickened. But there was no curbing the epidemic without focusing on the real causative factors, which were largely structural and not, as Jesmyn Ward noted earlier today in her address, they were not just the result of a single bad choice. When prison-seated TB epidemics did stem from cultural and cognitive and personal deficiencies, they were those of the policymakers, not the prisoners. It was a radically different and somewhat similar problem in my new stomping grounds, Haiti, not Harvard. As a new epidemic fanned an old one, Haiti was often in the US news, where we read about superstitious and backwards people who rejected modern medical care. But none was then on offer. As we learned while watching young people waste away before us, dying of AIDS, but also of eminently treatable tuberculosis. Now, no one laboring in the clinical desert doubted the potential contribution of medicine and of caregiving in general. If there's a similar utility to a career in medical anthropology, it's to challenge confident claims of causality about why afflictions, all afflictions, cut some lives short while sparing others. This can't be done without careful exploration of social context, which isn't possible without rescuing, sorry, the glasses still aren't working. I got good glasses advice last night from Pierre. He said, get progressives. I said, I am a progressive. Without rescuing more than a bit of history from the dustbin. In the affluent world, and after the great leap forward of vaccines, the history of infectious disease has been one of steady improvement in clinical outcomes. This began even before the development of less toxic antibiotics in the mid-20th century and continues among the fortunate to this day. It's not that no infection is invariable. It's not that no infection. I need new glasses, okay? Did I say that? Some infections are still invariably fatal. Rabies and a couple of others almost always kill in time, whether one lives in affluence or in poverty. But drug resistance aside, the general trend has been the same. A mix of specific and non-specific therapies have moved most microbes from causing disease in humans from the often fatal rubric to the eminently survivable one. I've been fortunate to witness such reclassification several times over the past 3 decades. AIDS is the most obvious example. Many critically ill patients I first cared for in medical school as a medical student in the 80s are survivors today. Some of them are now colleagues or friends rather than merely patients, but all remember when a diagnosis of AIDS was a death sentence. Today, for many, those dark days are beyond imagining, and that's because of antiretroviral therapy developed in the mid-90s. These drugs, like so many others, came from substantial investments in basic discovery science. But during the decade before these treatments were shown to decrease mortality, which was clear by 1996, there were, in Boston and as in Haiti, huge disparities in the course of HIV disease among the afflicted. That decade was, of course, the one in which I trained clinically. We learned during those years that to be transformed from people dying with AIDS to people living with HIV required making it through the awful 80s and the early 90s. And that only happened to those with access to rapid diagnosis and treatment of the opportunistic infections associated with the slow but inevitable destruction of parts of the immune system targeted by HIV. Such treatment often called for critical care, which is delivered in ICUs, for example, and almost always required supportive care, which isn't hand-holding, but nursing care. This was the work of nurses, doctors, friends and family, and activists who resisted the notion that some people were too poor to treat, or otherwise just not worth it. They resisted, in other words, the idea that the fruits of science were not for everyone in need. If the AIDS pandemic had a height and then a decline, it's because scientists, activists, and policymakers reaching all the way to George W. Bush came together to launch initiatives like the President's Emergency Plan for AIDS relief. More than 14 million people are alive because of it. And who knows how many infections have been averted. In some parts of Africa where I've worked, including Rwanda, pediatric AIDS is being wiped out. This integration of prevention and care only happened tardily and partially in West Africa. Fast forward to the summer of 2014, which found me and several friends from Partners in Health in Sierra Leone. Several members of the Tulane faculty were there, and they taught me a lot, such as the following. Although Ebola is a very different and much more acute affliction than AIDS, knowledge of these general trends, that is, moving from the untreatable to the eminently survivable, knowledge of these general trends might have inspired a bit of reticence among the therapeutic nihilists who populate the ranks of some echelons of health policy. The naysayers have always included some policy and disease control experts focused on settings of poverty, sometimes far away, sometimes right next door. They did not, however, include people like my Tulane colleagues who push for an effective vaccine and better therapies. They did not include my friends from Partners in Health. They certainly didn't include my classmate, Dr. Adora Okoli. She is a little bit younger than I am, if I'm not mistaken. She's here with her family today. She's graduating from a master's program in infectious disease epidemiology. And she shouldn't be embarrassed that we ask her to take a little stand for a round of applause. As your dean would say, now you can sit down. So, Dr. Okoli, what are we applauding? Oh, her courage, that's for sure. When Dr. Okoli fell ill caring for a Liberian man sick with Ebola, which is a caregiver's disease, I happened to be headed to Liberia. She knew, we knew, that changing the fates of the Ebola infected, moving them from the nihilistic category of untreatable to the aspirational and more honest one of treatable, was impossible without improving the quality of supportive and critical care. That's what she was doing in Lagos. But did Dr. Okoli receive enough of it herself? Not really, unless you meant her own self-care. She survived by chugging down the equivalent of Pedialyte, liter after liter. And that's hard to do when you're vomiting. When disease control efforts are untethered from clinical care, people flee it. That's what happened across Liberia, Sierra Leone, and Guinea. None of the Americans who fell ill in the course of the Ebola response died, and trust me, I know a number of them. And neither did many Europeans, but most of our West African colleagues with the same diagnosis, caused by the same strain, most of them died. They had the misfortune to be nursing and doctoring while black and in the clinical desert. That brings me to my only major point. He's really nodding happy. He's like, here comes the dismount. Paul did it. This brings me to my only major point beyond city envy. I mean, I so wish I lived here. That's the thing about tenure, though, you know. Public health practitioners can't continue to balkanize ourselves into our own, along the lines of our own interests. I happen to be a clinician, but that's surely not the only reason to note that. Even with the world's fearful attention trained on Liberia, Sierra Leone, and Guinea, mortality among the infected there remained appalling to the very end. With substantial local exceptions, the case fatality rate at the close of the epidemic hadn't gone down at all, in spite of improved surveillance and reporting. But it's not for surveillance and reporting that people show up in a clinic. They show up for care, not to be counted, sprayed, counseled, etc. And we would do well to take note of that. Not everyone is going to be a young and courageous physician who shows up for work, takes care of others, and then is obliged to take care of herself. As short-term clinical staff and humanitarians, and this is really my last paragraph. As short-term clinical staff and humanitarians, how am I going to bring this together and make it relevant to every public health graduate here? Oh, I will. As short-term clinical staff and humanitarians head off to the next crisis, as most have at the time of this ceremony, the region is as medically bereft as ever. It's more so if one takes note of the loss of a substantial fraction of its medical professionals, including 211 Sierra Leonean nurses, doctors, lab techs, and aides, some of whom worked with Tulane. So here's my extrapolatable general message. Let's study the social determinants of disease, but never turn our backs on the critically ill or injured. You didn't see that was where I was going? Dr. Okoli did, which is why she's taken this degree and why she's next helping fellow Ebola survivors. And I believe Tulane trainees and faculties all get this. So thank you for letting me say it just for you. And now, let us adjourn to the streets of the French Quarter to be pelted by shiny beads. Congratulations, class of 2018.
Thank you, Paul, for a really inspiring speech. And Tulane is special in many ways, but one thing which I really like about the university is that public health and medicine do work together all the time in a very close fashion, because those are our roots. We have common roots, right, to fight tropical disease and to go beyond that. So this was right on. And thank you, Adaora, for your resiliency, your courage, for what you're doing now and what you will be continuing to do, for having chosen to come to Tulane. And thank you for having made the School of Public Health and Tropical Medicine the central point of the President's speech this morning. This was very nice. Thank you.